on high-flow nasal oxygen led by Professor Michel Gang, and from domain 4 led by myself on non-invasive ventilation. These are my disclosure. Nothing is related to this presentation. Then, when we speak about non-invasive support in hypoxemic respiratory failure, basically we speak of different things. We have high-flow nasal oxygen. We have non-invasive positive pressure ventilation, and this includes or can include both CPAP and bilevel non-invasive ventilation. And in addition, both CPAP and bilevel NIV can be delivered either by face mask or with a helmet interface. Then there are a lot of things in the word non-invasive support. And if we quickly look on PubMed, and if we combine the name of each technique with acute hypoxemic respiratory failure, we can see that during the past 20 years, there were a lot of publications on the topic of using non-invasive support in acute hypoxemic respiratory failure. And this is true for nasal oxygen, this is true for CPAP, and this is true for bilevel NIV. Then definitely it was time to do some global and meta-analysis again on this topic. Then there were two domains about non-invasive support. One on high-flow nasal oxygen with 2 PICO questions that were answered, and one on CPAP and NIV put together with also 3 PICO questions that were answered. Then first, I'm going to show you the results of what was concluded for high-flow nasal oxygen. The first PICO questions was whether high-flow nasal oxygen was better than standard low-flow oxygenotherapy regarding mortality and regarding the need for intubation. By looking in the literature, there were 6 randomized studies that could be considered in the meta-analysis. And overall, those 6 studies put together show that there were no difference in mortality if high-flow nasal oxygen was used compared to standard oxygenotherapy. Differently, regarding intubation rate, high-flow was better than standard oxygen with a reduction in the need for intubation with a relative risk of 0.89. The second question regarding high-flow nasal oxygen was whether this technique was better or maybe inferior to the use of CPAP or NIV. And before, just about the last topic, you can see that the experts, based on the previous meta-analysis I showed you, that high flow is recommended to reduce the risk of intubation compared to low-flow oxygen. That this is a strong recommendation. But for mortality, no recommendation could be proposed. Just to note, it's the same thing for COVID-19. And if we now come back to the second question, which is the comparison between high flow and NIV or CPAP, you can see that there were few studies addressing the questions, 4 with the outcome on mortality and 3 with the outcome on intubation rate. And there were no difference when high flow was compared to CPAP or NIV regarding neither mortality nor intubation rate. And regarding this question, the experts were unable to make a recommendation in favor of one technique over the other. And also here we have quite similar conclusion, but a bit stronger in favor of CPAP NIV with a suggestion that was made by the experts, suggestion because the recommendation is a weak recommendation in favor of using CPAP NIV in COVID-19 patients, but only regarding intubation rate, not regarding mortality. Now we can go to the CPAP NIV domain, and here we had 3 PICO questions. First, is CPAP NIV better than conventional oxygenotherapy regarding mortality or intubation rate? And here, the primary analysis was done by including only the high and moderate quality studies. And this is important, because overall there were 11 studies that could have been included, but a lot of those studies were considered as low quality regarding the grade methodology. Then finally, in the meta-analysis regarding the outcome mortality, we only have 5 studies, and regarding the outcome intubation, also 5 studies. And there were no difference in mortality or in intubation rate in those 2 meta-analyses that compared NIV or CPAP versus standard low-flow oxygen. And based on that, our group said that it is currently not able to make a recommendation for or against the use of CPAP or NIV as compared to standard oxygenotherapy in acute hypoxemic respiratory failure as a first-line treatment. And oppositely, there is a suggestion in favor of using CPAP in COVID-19 patients because of one positive study regarding the reduction of the need of intubation. The second PICO questions of the NIV CPAP group was whether there was better to use helmet compared to face mask as an interface if we deliver CPAP or NIV in case of acute hypoxemic respiratory failure. And here, there was only one randomized control study available, a monocentric and small one with 83 patients included. This study is clearly positive in favor of helmet, both on intubation rate and on mortality. However, there is only one study, it's a monocentric study, it's a small study, it was terminated early, and there are also other concerns regarding the methodology, especially the control group that was treated with another type of ventilator compared to the helmet group. For all those reasons, even if this randomized control study was positive, the experts considered that this was not enough to make a recommendation for or against the use of helmet compared to mask interface, neither for decrease in mortality or intubation. Then we can use it, but we don't have to use it based on this recommendation. And the last PICO question for the CPAP NIV domain was whether it's better to use NIV, bi-level NIV, compared to CPAP to reduce mortality or intubation. And here, it was easier. There were no randomized control trial addressing the question. And of course, it was not possible to give any recommendation regarding this specific question. Then, if we summarize the results of the domain 3 and 4, we can say that high flow is recommended compared to standard oxygen to decrease intubation, but again, not mortality. Regarding the other questions, whether high flow or CPAP NIV is better, whether CPAP NIV is better than standard oxygen, or whether helmet is better than face mask, we were not able to give any recommendations. But this is not the end of the story. Why? Because there are promising physiological results, not coming from randomized control trial, but coming from high-quality physiological studies that suggest that we have things to learn in addition to what we know today. As an example, I show you those interesting results from Domenico Grieco about the use of helmet compared to high-flow nasal oxygen. And as you can see here, with helmet, you can have better oxygenation, same PaCO2, and very interestingly, overall, you can decrease the inspiratory effort. And as we know that strong inspiratory effort are probably related to PSILI during non-invasive mechanical ventilation, this can definitely be of interest. And what is maybe even more interesting is that the effect of helmet was particularly interesting on respiratory effort when the effort was increased at the beginning of the treatment. And in those patients who had strong efforts, the use of helmet was associated with a decrease in the transmural lung pressure, the stress applied to the lung parenchyma, which also suggests that in those specific patients with strong effort, we could have an advantage of using helmets compared to high flow. And based on the available data that come from physiological studies, we have proposed a strategy. This, of course, has not been tested in randomized controlled trial, but based on physiological data. And we could maybe test in the future the idea of using high flow in the less severe patient, high flow in the more severe patient with absence of increased inspiratory effort, and some positive pressure in the patients who have increased effort at start of the treatment. But of course, this can be only done with strict clinical monitoring, and as always, in case of absence of improvement, we have to go to intubation. And again, this has not been tested prospectively, but maybe it's the next step. Thanks for your attention.
Thank you very much for this very clear presentation about the guidelines in the field of non-invasive support. Questions, comments, suggestions? Yes?
Hi, I'm Giacomo Grasselli from Milan. Thanks, Lise. I have a practical question. So about, you said that it's very important to monitor patients during non-invasive respiratory support, and I completely agree. And that we have to understand which is the right time for intubation. You know that before COVID, the recommendation was, let's say, let's wait an hour and see what happens after 1 hour, and if the patient deteriorates, he has to be intubated. During COVID, we were forced to keep patients for weeks on CPAP or non-invasive ventilation. So what would you recommend now? What would be a reasonable period of time of observation before saying that the patient has failed and he has to go to intubation?
Very good and very difficult questions, because probably that it depends from one patient to the other. What we can say quite clearly, I think, is that if we have a patient that is still in respiratory distress under a technique, it can be high flow, it can be NIV, it can be CPAP, it's probably going to proceed toward intubation. Then for those patients, we should not wait. For the patient who don't have increased effort, at least we don't think they have, and that's the problem because it's difficult to monitor bedside, we can wait, but how long? Probably, I would say, except for COVID, for sure not more than 24 hours, but it's totally arbitrary.
Lise, may I ask a question? We talked a lot about subphenotypes, so probably also for this field, there are probably some phenotypes we should propose or invent in the next future to try to identify the good candidates for this or this treatment. And what do you think about little bit as Giacomo said, a test, a physiological test, rapid test, to have the answer in some minutes, to test the patient, to test the system, and to define a subphenotype like this. Because physiology is very important, so we can define subphenotypes using physiology. This is my opinion.
I think it's a very good option, and one thing that is quite easy to measure, except with helmet, is tidal volume during at least non-invasive ventilation. Then we could imagine that a phenotype is a patient who under NIV has a low tidal volume, not a low carbon dioxide, and no respiratory distress. This one could be one phenotype, and oppositely, we could imagine having one patient who has huge tidal volume related to big effort, probably, and also low carbon dioxide in blood with high minute ventilation. And those ones, good idea, but the problem is how we can monitor effort.
Antonio Pesenti.
Thank you very much. Lise, just a simple question. Can you specify whether, when you talk about CPAP delivered by helmet, you're talking about free flow, right? Not ventilator delivered CPAP.
Yes, it's free flow.
Thank you.
Thanks for the precision.
Fantastic. Thank you so much.